Yeah, ma'am. So we are on live, ma'am. I'm starting session.
Yes.
Yeah. So very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the 23rd episode of Knowledge Update series. So I take my pleasure in welcoming the chief guest, special guest of honor, speakers, chairpersons, and delegates for another exciting session today on breaking barriers in infertility and fibroids and endometriosis. So I would like to welcome the conveners for today's program. So let me have Dr. Priyanku Rai sir. Sir is the consultant infertility gynecology endoscopy, no IVF, and Roy's Clinic Siliguri. Sir is the national coordinator for Technology Committee FOXY, E-Zone coordinator for Infertility and Endocrinology Committee FOXY, and joint secretary Siliguri Obigin Society for E-Zone UFOXY 2020. So Sir has published various journals to his credit, and he has also received various awards to his service. We welcome you, sir. And I would like to welcome the next convener for the today's program, Dr. Diksha Gausabi Sharma, ma'am. Madam is currently the director of Pushpanjali IVF, Pushpanjali Hospitals and Research Center, Agra. Madam is the North Zone Coordinator, Technology Committee, FOXY 2019-21. Madam has also received various awards and credits to her service and in academic endeavors. So we welcome you, ma'am. And we would like to go for the next convener for the today's program, Dr. Vritika Kishore, ma'am. Madam is the consultant at Vridhan Arogya Deep Hospital, Vridhan, Mathura. Madam was the past president of Mathura Obigin Society, executive member FOXY, IAEC, executive member SFM, SFM UP chapter, advisor Adolescent Health Committee. And Madam has also received Wellness of Women Award from FOXY. And Madam's special interest is preventive oncology, high-risk pregnancy, adolescent health and infertility, ultrasound. So we welcome you all, ma'am. I'm handing session to the conveners for taking the program further. Thank you, Nanda.
Thank you, Team Shield. It gives us again an immense pleasure to welcome all of you to this wonderful 23rd session of the KU webinar series. And this is like almost for the last 1.5 years that we are continuing with this program. And of course, the program director for this program is Dr. Pratibha Singh ma'am, and she has taken a lot of effort in continuing with this program over the last 1.5 years. So first of all, I would like to just tell a brief about the KU webinar web series that we usually have. That is basically we have initially we have this quiz, which is a very exciting quiz that goes out on the WhatsApp platform, and the answers come to us, and based on that we have the prizes that are given on the fastest finger first. And this really keeps us going, motivates us, because every time we get a lot of answers from seniors, juniors across the country, from Kashmir to Kanyakumari and from Gujarat to Manipur, I would say, is where we get the answers from. So, and then after that, we have a talk or an oration that I must say, and then after that, we have an interesting debate, which is the last of the last of the program for this webinar. So first of all, to welcome all the faculties and delegates present here, I would like to welcome Dr. Pratibha Singh ma'am, who is a program director. She is a consultant endoscopic surgeon and infertility specialist practicing in Bhagalpur. Ma'am is currently the national coordinator of the International Academic Exchange Committee. She has received a number of awards from various organizations and has been a first for various positions in the Bihar and Jharkhand OBGYN as well as other organizational chapters. So it gives me pleasure in welcoming ma'am here. I would request her to say a few words to everyone present
here. Thank you, Dr. Priyanku. And a very good evening to all of you. A warm welcome to all our viewers who have joined today for this Knowledge Update webinar. And this is indeed a great privilege to be associated with you all. And today, our scientific program is on the newer updates in the management of endometriosis, infertility, and fibroids, where we have exciting quiz, which already Dr. Priyanku has told, that we have quiz, then scientific deliberation by an expert, and a debate by our young upcoming gynecologist. But before we start our program, let me welcome our most awaited chief guest, Dr. Alka Kriplani Madam, past President FOXY. And Madam, I'm truly blessed by your presence today. Thank you for joining and thank you for accepting our invitation. Now our guest of honor is another very dynamic personality, past Vice President FOXY, and she is also the organizing secretary of the most awaited AICOG conference, which is going to be held in Indore madam, and welcome to this forum, madam. Thank you for joining, and we are looking forward to meet you in Indore soon. So welcome, madam. And now our special guest is again a truly special for us, always there to help me in all circumstances. I would like to welcome Dr. Subhash Malya, Chairman, Endoscopy Committee, FOXY. And this forum is not new for you. So welcome once again, Dr. Subhash. Now, thank you so much for joining. Now, with folded hands, I would like to welcome our guest speaker, Dr. Prakash Trivedi, sir. He is past president FOXY, and whose talk on newer treatment of fibroid, endometriosis, and infertility will open a new arena of hope for we gynecologists to manage these difficult situations, which will help and satisfy our patient. So, sir, we are really eager to listen to your deliberation today. So, welcome, sir. And with your presence, this webinar, has made this webinar really worthwhile. And in spite of being so busy in SR elections, you have accepted our invitation. So thank you so much, sir. I think he'll be joining in a few minutes. And I also want to welcome our chairperson, Dr. Murlidhar B. Pai, sir, from Sikkim, and Dr. Surjit Kaur, madam, from Jalandhar. So welcome, madam and sir, to this forum. Thank you so much for joining. Thank you so much, sir. And today the debate on the laparoscopy for all infertile patients, yes or no, is going to be very useful. And for that, I would like to welcome our debaters, Dr. Aarti Luthra and Dr. Reema Sarkar from Dehradun. And we are really waiting for an action-packed debate today. So welcome both of you. And to judge them, we have equally efficient judges. So I would like to welcome Dr. Gaurav Desai from Mumbai and Dr. Monica Gupta from Delhi. So welcome all of you. Now, lastly, I would like to welcome our conveners, Dr. Priyankur Roy, Dr. Diksha Goswami, and Dr. Vartika Kishore. And from here, I hand over the sessions to them. So once again, a warm welcome to all of you, and thank you so much for joining. Thank you. Over to Dr. Priyankur.
Thank you, ma'am, for that wonderful welcome to everyone. So now it gives me pleasure in announcing the prizes of the surprise quiz that we had last episode. So this was the quiz that we had in the episode 22, and I would like to announce the question first. According to FIGO guidelines, indications for cervical encerclage include all except women with two or more mid-trimestral losses was the answer for this. And let us look at the winners. Can we have the next slide, please? Yeah, so I would like to welcome and congratulate the winner of the quiz, Dr. Shefali Pandey from Kanpur. Congratulations, ma'am. She wins a certificate and also a book on preterm labor, managing risk in clinical practice. So congratulations, Dr. Shefali, for this. Next, we have, can we have the next slide? Yeah, so we have this fastest finger first prizes that we also give away on the KU webinar series. And again, it's Dr. Shirali Runwal. I have been telling this every webinar, but I think I don't get bored or tired of saying this because she's a postgraduate student doing in practice a postgraduate student in Gwalior. Every episode till now, the 23rd episode, I think every time she has won a prize for the quiz, for the surprise quiz or the quiz that we have during the program. So Shirali, congratulations once again. I'm sure you have a great future as an obstetrician and gynecologist, and FOXY will have a great person in you as a FOXYan basically. So congratulations, Shirali, once more. Next prize winner, we have Dr. Kumudini Jha ma'am from Darbhanga. So congratulations, Dr. Kumudini Jha, for winning the certificate and participating in this quiz. Next, we have with us Dr. Shmiti Saxena from Dehradun. So she also wins a certificate for the fastest finger first for answering this question correctly during the last episode. And the last one we have from Pudukottai, Dr. Salim Ahmad, who also wins a certificate for the same. So congratulations to all the winners, and would request you to kindly keep participating with us because your participation keeps us going and helps us to continue with this episode over and over again. So now we move on to another pleasurable job of today's evening. I would like to invite, first of all, the chief guest of today's evening, none other than Dr. Alka Kriplani ma'am. Can we have the next slide, please? So everyone knows ma'am. She is an ex-professor and head Department of OBGYN at the prestigious AIMS New Delhi. She has been the past president of Foxy. She is currently the director and head at the Paras Hospital in Gurugram. She has been the past president of, I would say president and past president of most of the organizations that we can think of. Foxy, GESI, DGES, and the AOGD. Editor of most of the journals that we know of. And also, I'm proud to say that she has been a Padma Shri awardee from the President of India in 2015 for, of course, her distinguished service. And of course, being a teacher of teachers, she has also received the BC Roy National Award for Eminent Medical Teacher. Ma'am, it's a pleasure that you have joined us. Would request you to kindly say a few words to everyone present here.
First of all, very good evening to everybody. Thank you, Dr. Priyankur, for your kind words. And I know you must know that you are so aggressive. Everybody knows you. You are working so hard, and God bless you. We all seniors will be replaced gradually by you people. And we are very proud that the younger generation is so active, so humble, so nice. You did that. You are Foxy, and you stole everybody's heart, Priyankur. And second, I would like to appreciate Dr. Pratibha from Bhagalpur. She kept on, chasing me for months. And I really appreciate her sweet voice, sweet invitation. And you see how much this technology has changed. The Bhagalpur place, previous years, we never thought we will be communicated. And these webinars, Pratibha, I give you all the credit for bringing Bhagalpur to center stage, making it such a lively and active society. And as I promised you once, after Prakash, I will definitely will be coming and delivering a lecture of your choice. Thirdly, has Prakash joined? Because the topic is so good. And I would like to appreciate you people for putting this quiz. Because you see, we oldies are always there in all conferences, all lectures, and these youngsters are busy in their practice, rearing up their children, and they never used to come for conferences. And these debates and these your MCQs and making them win is a very good way to attract youngsters. So I really appreciate, Pratibha, that you people are putting these quiz, giving them prizes. So we need youngsters to listen to our lectures. So the purpose is served. And what to say about today's speaker, Dr. Prakash Trivedi, apart from being a very, very good friend from decades, he is an excellent person, excellent human being, excellent surgeon, excellent teacher, and an excellent student. I say Prakash is a student. He keeps learning. And that is the reason he is where he has reached in life. Prakash, it's always a pleasure to listen to you. And we learned so many practice points from you. So I think everybody is going to enjoy this evening because your speaker is such a learned person. And my dear friend from Dehradun, and I'm sorry if I'm forgetting the name of other person, for that debate. That debate is very, very important because in day-to-day practice that topic. So Pratibha, thank you for putting such interesting topics. And I think I should stop here. Time is limited. And Prakash, it's a pleasure. I will also listen to your lecture. Thank you, Pratibha, for the invitation. And I really appreciate you, Pratibha, putting Bhagalpur to such a forefront and having, they see your face is shining. You are shining away, oozing such positive energy. I really appreciate you girls, how much effort you make, to make academics in those places. Salute you.
Thank you, madam. Thank you so much. Thank you.
Thank you, Alka ma'am, for that wonderful words. Would also request you to kindly stay on for some more time, ma'am, for felicitation.
Sure.
Thank you so much, ma'am. So next, I would like to invite our guest of honor for today's evening, none other than Dr. Archana Basre, another accomplished surgeon, infertility specialist, I must say. into fetal medicine as well. Ma'am has been the vice president of FOXY, is the organizing secretary of AICOG 2022, I must say, in Indore, which we're really looking forward to. She has been the Imaging Science Committee chair of SAFOG and also the fellow representative of AICC RCOG. She is a managing committee member of ISAR IOG as well as ICOG. Welcome, ma'am, to the platform. Requesting you to say a few words to everyone present here.
Thank you, Priyankur, for the kind words. And thank you, Dr. Pratibha Singh, for inviting me here today. And I mean, it will be a great opportunity to listen to Dr. Prakash Trivedi. And thank you, Dr. Alka Kripalani. She has brought out all the points of Priyankur and Pratibha, so that we all know that they are really working hard in the FOXY, and everybody knows them. And I must appreciate that Pratibha bringing Bhagalpur to the center stage. So it is a very important meeting today where you'll be covering endometriosis, fibroid, and infertility. And I'm sure debate and talk by Dr. Trivedi is going to enlighten everybody. And I extend my warm welcome to all of you to Indore for AICOG 2022 from 4th April to 8th April. And please do come in large number. We all will have a good academics and good program for the cultural programs as well. So all the best for today's webinar, and I'm sure many more Pratibha laurels to you in your credit. So congratulations for organizing it, inviting me, and all the best. Thank you so much.
Thank you, madam. And please stay on for a few more minutes, madam.
Sure, I will be.
Thank you so much, Archana ma'am. And on behalf of her, would like to extend, of course, she invited all of us to the Indore for the academics, but I'm sure hospitality is also due and we'll have a great fun time in Indore as well. So
sure, we will definitely.
Indore, ma'am. Thank you so much. So now it gives me pleasure in welcoming my very good friend, elder brother, Dr. Subhash Malia, who's a special guest in today's webinar. He is a wonderful endoscopic surgeon, currently the chairperson of the endoscopy committee, chairperson of the medical legal committee of KFOG, secretary of the Calicut OBGYN Society, and doing wonders there. He is currently a DNB guide and examiner, and also has received a number of awards from various organizations. So Dr. Subhash, it's a pleasure you have joined us, requesting you to kindly say a few words to all present here. Dr. Subhash, we are not able to hear you. I think he is having some signal issues. Dr. Subhash. Okay.
Thank you very much, Priyankur.
Yes.
And the audience, since I'm traveling by train, so apologies for the.
I think we have lost his connection again. So we'll move ahead with the program, and when Dr. Subhash joins us, we'll take his blessings for him. Sure. So, so thank you, our chief guest, guest of honor, and special guest. Thank you for being there with us. So now we come to the Know Your Legend quiz. So basically, this photograph of this gentleman is circulated on the WhatsApp groups. We get the answers from everyone, and based on what we exactly got, we take a call on how the prizes, etc. on. And you won't believe, this is the 23rd episode, and I probably had answered only 3 correctly myself. But every time within the first couple of minutes, there are so many answers that come in for this quiz. So this time, the photograph was put of Dr. Palmer. We all know him. He's a French gynecologist, pioneer in gynecological laparoscopy, inventors of the Palmer's point, Palmer's sign, and many procedures as well as instruments. So, so basically, I would like to first of all congratulate the winners of this quiz. So I would like to congratulate, first of all. Can I have the slide, please? I would like to first of all congratulate Dr. Ranjana Sinha from Patna. So ma'am wins the first prize for answering this quiz correctly, and she wins a book on operative gynecologic laparoscopy principles and techniques. So she'll get the certificate and the book that will be sent to her by courier. Congratulations, Dr. Ranjana ma'am. The second prize winner is Dr. Dinesh Kanfade from Mumbai. So congratulations, Dr. Dinesh. Wins a certificate and also a book on the SAGES Manual Volume 2 for Advanced Laparoscopy and Endoscopy. Congratulations. And the third prize goes to Dr. Jyoti Chaudhary from Bhagalpur. So congratulations, Dr. Jyoti. She wins a certificate and also the book of the SAGES Manual Volume 2. So can I please invite now Dr. Alka Kriplani ma'am to kindly felicitate the winners. Alka ma'am.
Sir, I think so. Ma'am lost the connection.
Lost connection. Okay, Archana ma'am, are you with us, ma'am? Okay, I think she's also lost her connectivity. Sure. Dr. Subhash, I see you. You have rejoined. If your connectivity is good, can you please say a few words? No. Okay. Sure. We'll go ahead then. Congratulations to the winners. We'll get the certificate and textbooks that will be couriered to you. So next we have our consistent winners with us. These are people who answer every time for all the quizzes and get the answers correctly. So this time first we have with us Dr. Freni Shah from Mumbai. Congratulations, Dr. Freni. Wins a certificate as well as a book on obstetrics and gynecological ultrasound for beginners. So congratulations, Dr. Freni. We have next with us Dr. Srivastav from New Delhi, who also wins the consistent winner prize. Congratulations. Next with us, we have Dr. Rajiv Srivastav from Dehradun. So congratulations, Dr. Rajiv, for answering it correctly every time consistently. Next with us, we have Dr. Santosh Sinal from Agra. Congratulations, Dr. Santosh. Then we have Dr. Nirmal Kumar Gupta from Sitamarhi. So congratulations, Dr. Nirmal Gupta. And then finally, we have Dr. Yukti Bharatwaj with us from New Delhi. Congratulations, Dr. Yukti, for answering the prize consistently correctly. So next we move on to our next category of prizes. That is the certificates for fastest finger first. And we would like to felicitate Dr. Purnima Jaydev from Bangalore, Dr. Abharani Sina from Patna, Dr. Prativa Mangotra from Jalandhar, Dr. Sujata Sarma from Assam, Duliajan, Dr. Anita Sabarwal from New Delhi, Dr. Kanchan Sharma from Kanpur, Dr. Vasanti Lad from Nasik, Dr. Nutan Upadhyay ma'am from Saharanpur, Dr. Shubhanjali Sen from Agra, Dr. Karuna Jha from Ranchi, Dr. Sumitra Sundaraman from Chennai, Dr. Varsha Prapanna from Vadodara, Dr. Anshumala Shukla from Mumbai, Dr. Charu Maheshwari from Aligarh, and Dr. Anupama from Muzaffarpur. So congratulations to all the winners. I see we have Dr. Murlidhar Pai sir and Dr. Prakash Trivedi sir with us. So sir and Murli sir, if you can just say a few words of felicitation to the winners, I think they'll consider themselves greatly privileged.
This is so wonderful thing that is happening from this organization. And Priyankur, as always, you have been a wonderful host and you have a way to conduct the programs. But most importantly, the participants who have actively participated and won the prizes. Nothing like that. Debates and the quizzes are the toughest part of life. And as you said, you have at least won 3. I would not have won even 1. No matter how much I know, these quizzes and MCQs are always the tough ones. And you need to have a very sharp brain for that. And you need to have a very good acumen and lateral knowledge, what we say. So I congratulate all the winners and I request everybody to keep participating, whether you win a prize or not. Thank you.
Thank you.
Thank you so much, sir. So this time we totally had 112 entries, out of which 105 were correct. And only there
That's
was
great. That's
7
great.
that were wrong. Yes, sir.
So how do you do fastest finger first means the whichever comes first answer?
So once the photograph is circulated in the WhatsApp groups, the number is given to send the answers. Whichever answer comes first is how we take it as the fastest finger first.
Okay.
So Prakash sir is there with us, sir. Can I kindly request you to kindly say a few words of felicitation to the winners? That will be a great laurel to this to the winners, I believe, sir.
Priyankur, you can hear me.
Yes, sir, we can, sir. Okay. So we will first, as we do it every time, we will once have our winner, the consistent. This time we have the consistent prize winner, Dr. Freni Shah from Mumbai.
Priyankur, can you hear me or not?
Sir, we can hear you, sir. Prakash sir, can you hear me, sir? Okay, so this time we have with us Dr. Freni Shah, who from Mumbai, who is our consistent prize winner, and she is going to talk to us about Dr. Palmer. So can I please invite Dr. Freni to the platform? She is a consultant at the Shah's Women Wellness Clinic in Mumbai, clinical associate at the Ganatra Nursing Home in Mulund, and she has won a number of prizes from MOGS and other platforms as well. So I hand over the platform to Dr. Freni to kindly enlighten us about Dr. Palmer.
Hello.
Yes, Dr. Freni, audible. Please go on.
Yeah. Good evening.
You can hear me now.
Pratibha ma'am, I think sir's connectivity is an issue. You can just
Yeah.
call to sir.
So I think Dr. Freni.
Dr.
Dr.
Freni,
Freni, will you start?
Yeah, good evening, everyone. I would like to thank Shield and Pratibha ma'am for giving me this opportunity. The last time's legend, the quiz, we would like to talk about them. So it is Raoul Albert Charles Palmer, known as AC Palmer, a French gynecologist and renowned tubal and vaginal surgeon. He was born in Paris on 29th of August 1904 to a Swedish parents. Renowned international teacher as well he is known for. In 1974, he was elected fellow ed Undum of the Royal College of Obstetricians and Gynecologists, and he was pioneer in gynecological laparoscopy. He's a trained gynecologist and became head of gynecological research at the Faculty of Medicine in Paris in 1934. During World War II, he started his experiments with intra-abdominal endoscopy. And at the same time, he had to make his own instruments as most of the manufacturers were out of business or pursuing some other ways of making money, living, or in prisons at the war camps. He used cystoscopy to visualize female genital organs transabdominally and transvaginally. He realized controlled peritoneum is required for transabdominal approach, and he advocated close control over intra-abdominal pressure, which should not exceed more than 25 mm of mercury, and the speed of insufflation should be limited to not more than 400 to 500 cc per minute square. He established safe criteria for insufflation using CO2 in lieu of oxygen via Verey's needle. He introduced use of trendelenburg position and mobilizing of the uterus by a transvaginal cannula. He is also known for the Palmer's sign, which is the rhythmic regular contractions of the uterus at around 6 to 8 weeks of the pregnancy. He was the first one to retrieve a human oocyte from a patient via laparoscopy in 1961. In 1955, he showed the first laparoscopic motion pictures filmed in 8 mm color. The instruments were quite heavy and the diameter of the endoscope was 10 millimeter. He was pioneered in laparoscopic tubal ligation and electrocoagulation. He is remembered for laparoscopic forceps and Palmer's point. One of the earliest colposcopists in France. He assisted Viviana Grain Armitage in 1938 to demonstrate his technique of vaginal hysterectomy. He did pen and ink drawings for Green Armitage's paper on the subject in the Journal of Obstetrics and Gynecology of the British Empire in 1939. He was the one who switched to general anesthesia for laparoscopic procedures, which were initially done in local anesthesia, for which the females used to fail to follow up for the same. He traveled extensively and used cystoscope to visualize female organs transabdominally and vaginally. He was a great teacher. He mastered 5 languages, written and spoken, and because of which he could teach and influence many gynecologists about the use of laparoscopic procedures. Other gynecologists, to name few who were influenced by them, are Sir Melvin Cohen, Richard Finkelstein, and Patrick Stewart-Type. Some of his publications are his first article on abdominal endoscopy, soon after the war ended, was published. It covered the 250 coilioscopic gynecologies that he had carried out. Some other publications, as you can see. Some honors and awards to his names were honorary member of Royal Society of Medicine in 1958 and other national societies of gynecology like Australia, Austria, Germany, and many more to name. He was president of Society of Francis de Gynecology in 1962, vice president of the International Fertility Association from 1964 to 1967, directed the Society Internationale de Endoscopie from 1969 to 1972, and definitely the fellow of Royal College of Obstetrics and Gynecologists in 1974. Just we all know, as we know, that behind every successful man, there is a successful woman, and same was with Sir Palmer also. His wife, Elizabeth Palmer, assisted him and guided him and supported him in all his experiments, and Sir is famous for the same. Thank you for patient hearing.
Thank you and congratulations, Dr. Saini.
Thank you, ma'am.
Thank you so much, Treni ma'am, for that for the lovely intro that you gave to Dr. Palmer. So next with us we have, of course, the awaited talk on new treatment of fibroid, endometriosis, and infertility, and we are all waiting to hear to Dr. Prakash Trivedi sir for this talk. So I would like to welcome the chairpersons for this session. Dr. Mullidhar Pai sir. Sir is currently the Dean, Sikkim Manipal Institute of Medical Sciences, Professor of OBGYN. He has been the professor and head at the KMC Manipal and also the MMMC Malaysia. There are a lot of things you can read in this slide, author of a textbook, number of guest lectures, publications, but something that I would like to mention over here is a wonderful singer, a wonderful human being, and a thorough teacher, I must say, because every day he does this webinars for students alone so that they can learn. And that is a wonderful initiative that Sir has taken up. So welcome, sir, to this platform. And it's a pleasure that you have joined us today. Thank you, sir. Next with us, we have as a chairperson, Dr. Surjit Kaur. Ma'am is Vice President of the ISAR Punjab chapter, past Secretary of the IMS Jalandhar chapter, President of the Jalandhar OBGYN Society, and is a life member of NARCHI as well. She is a laparoscopic surgeon, colposcopist, as well as an IVF specialist. Welcome, Surjit ma'am. I would now like to invite Dr. Surjit to kindly invite our guest speaker, Dr. Mullidhar Pai sir, to this platform.
Dr. Prakash Trivedi sir.
Dr. Prakash Trivedi sir, I'm so sorry. Can I invite
Dear friends, all the viewers on this virtual platform, distinguished guests, speakers, chairpersons, and faculty members, good evening to all of you. Thank you, Dr. Pratibha, for inviting me for such an important webinar. New trends of fibroids, endometriosis, and infertility. So this is a very important topic for infertility specialists. It is my proud privilege and honor to introduce Professor Dr. Prakash Trivedi. He is a renowned endoscopic surgeon, and many times we have listened to him and seen his surgeries. Now we are going to listen him. Professor Dr. Prakash Trivedi. He is a pioneer of hysteroscopy surgery, laparoscopy suturing, 3D laparoscopy in a bag morcellation, and urogynec in Asia. He is a director of Dr. Trivedi's Total Healthcare Private Limited and Akar IVF Center. He is a gynec endoscopist surgeon at Fortis Mulund Hospital, Mumbai. He is a President ISAR 2020-21. He is a Maharashtra ISAR Chairperson 2021 and 23. He was past president of IAGE Hoxie. He is a scientific chair of AAGL in India, 2016 to 2021. He is a member of FIGO Endoscopy Committee, 2015-18, AOFOG Endoscopy, 2020-22. In spite of all this, he has outstanding achievements. He is a gold medalist, MD from Bombay University in 1983.
Madam, stop the introduction. I am very apologetic and I'm very
Sir
sorry.
has a very vast experience and achievements and many awards. It cannot be completed in few words. Sir, you are an excellent person, excellent teacher. So, sir has a very published 10 outstanding international teaching books.
What I'm trying to tell is stop the introduction.
Sir. Thank you, sir. And I invite you for your deliberation, sir.
I apologize for the nonsense with our staff it did. But that's beside the point. Let's come to the point. अभी मेरा तो ये तो आएगा है ना स्टेज स्क्रीन आएगा. Yeah. I am so apologetic. I am so sorry that a lot of time was wasted. By my home people. Now, Priyankur, Murlidhar Pai, and everybody, I totally apologize for the delay. This is a patient from Australia with three fibroid, nephrostomy done. And after that, you have a patient from Australia who is having a hydroureter. Nowhere in ASRM, this is the ureter, this is not the IVC. See, in a year, we are coming out with such a big research on fibroid, which will stop 60% of the surgery of fibroid. I apologize, there was delay. Now, this is a patient, one from Australia, second one from New Zealand. Nobody knows how to handle this fibroid. You saw that ureter. This is how we have handled. My point is very simple and clear. कि अगर आपको fibroid का कुछ समझता ही नहीं है, तो आप कैसे expert हो गए? ART person and endoscopy is a totally novice who don't know what fibroid is due to. This is the case I operated at Krishna Kumar's place, our president of IAG. This was a patient which was an angio lipoma. And he always tells me, sir, क्या problem है? आपका क्या जादू है? 14 साल से infertility है. 4 महीने में patient pregnant हो जाती है. क्यों हो जाती है? मालूम है, because I am not talking as a laparoscopic surgeon. I am talking about fibroid research for 2 months. I've read so much. I've read so much, and we will come out as AGL chair of what fibroid should mean to you. This is not out of air. There's so many details, and that's why this talk is important. I apologize for some delay which happened. बड़े लोग हैं, मुरलीधर भाई हैं, प्रियंकुर है, सब लोग हैं. छोटा मोटा होता है. Now, this is a patient. Nobody bothers. whether this is degenerated fibroid or not. Small base, we मेरा भी सिस्टम सोने पे चला रहा है. I don't blame anybody. It's a problem which our people didn't realize. होएगा, शुरू भी होएगा, सब भी होएगा. But these are degenerated fibroid. A base 6 millimeter का होता है, 6 centimeter होता है. And the thing is so bad that when they have when they have bad degeneration, my point is, okay, 14 centimeter, you kill it with MRI, you kill it with whatever you want. Where does the destructive tissue go? It goes nowhere. How do the lymphatic system? Oh, I'm very happy that my film is not running. I am very happy because this shows only competence of my people around who don't even understand what I'm talking. Let me move to the next point. Maybe possible we move to the next point, क्या प्रेजेंटेशन में अपन लोग मदद करते हैं. में सबसे बड़ी मदद तो बीवी ही करती है, बट उनको समझता नहीं है. नहीं, उनको समझता नहीं है. 1 मार्च को इस साल की जगह मैं फाइनलाइज कर रहा हूँ. 1 मार्च को मेरे बच्चे की जगह फाइनलाइज करता हूँ. और पॉइंट ये अभी घूमते ही रहेगा. So the point of the matter is that we don't know any damn thing about fibroid. Who is the expert? ART person. Who is the expert? Endoscopist. I have so many things. I hope I can progress in my next slide. I don't want to show surgery, but this is what our system makes us. Our system doesn't know what the hell we are interested in. Waste of time. Forget about everything. Fibroid has 4 points. First is, how does fibroid track? It's genetic. Genetic is the biggest thing. I have all the slides, courtesy to all my people. This is not running. I am not bothered about it. I can take 4 minutes to make you understand. 4 points. Genetics decide how fibroids come. Small fibroids are generated by MED12 genes. Big fibroids are generated by HMGA overexpression. I am not even interested in showing all this rubbish film, which I'm very kind that my wife and everybody in the system already stopped it. Point number 1. Point number 2 is prolactin is raised in fibroid, inside the fibroid. This is the point number 2. Point number 3 is aromatase inhibitor is 3 times higher in the level in fibroid than in normal tissue. So I told you 4 points. First is genetics, second is prolactin, third is aromatase inhibitor, What I'm trying to give an idea is all of us are great. We are great ERT people. We are great endoscopists. I can remove 18 fibroid. ART people can produce a base embryo. Who the hell has understood fibroid? That is my problem. My point is in 2023, as the chief of fibroid of age in the world, I am going to give a solution wherein 60% of fibroid surgery will be gone. Pardon me, this is running or not running. I can't control all these nonsense. But the point is, I am a laparoscopic surgeon. We remove so many fibroids. And this is exactly what I'm trying to tell you. This is stuck because everybody in the mind are stuck. That they don't want to understand कि fibroid से क्या होता है, fibroid क्या गलत करता है, fibroid नहीं करता है. Uska 2023 में our publication will come. We will solve all the problem and 60% of fibroid surgery will be stopped. What I'm trying to give you a very simple idea is, I'm very happy with Bhagalpur and everybody who is there. But what I'm trying to tell you, कि जो सब्जेक्ट आपको मालूम ही नहीं है, उसमें आप एंडोस्कोपिक सर्जन की तरह एक स्टेटमेंट देते हो, एआरटी की तरह आप स्टेटमेंट देते हो. अरे स्टेटमेंट वैलिडेट कहाँ हुआ है? Wait for 2023. We'll validate and we'll give you the biggest and the best which India has ever produced in the world. फिल्म नहीं चल रही है, चलता है. It's okay. It's part of the game. But I am honored and I am very proud of being part of this event. Thank you very much.
Thank you, sir.
Thank you so much.
Yeah, Diksha.
Thank you so much, sir, for your words of wisdom. And it was like a new, as a president of ISAR, your words of wisdom really helped us to understand that how we should approach every case, sir. So over to our chairpersons today for their...
The important point is, we'll change the world. I'm telling you, in fibroid, we'll change the whole world on treatment of fibroid. Medical, surgical or otherwise. But I'm very proud to be participating in this. Films वगैरह नहीं चली, ठीक है, छोटा मोटा issue.
Thank you, sir, for your valuable time, sir.
Request Dr. Muralidhar Pai, sir.
Yes, yes. I request our chairpersons for their comments, please, and to conclude this session.
Yeah. So thank you very much, Dr. Prakash. I know that that there was a technical problem, so the slide could not move. It's all right, but we know all that you are the greatest laparoscopic surgeon in India, and I have seen you personally do the biggest possible fibroids, 20-weeker, 25-weekers, which we all don't dare even do with the open laparotomy. I have seen you do it through laparoscopy and in the endo bag when the whole world was telling don't do laparoscopy for fibroids, but you have demonstrated. I saw you demonstrate this in Trivandrum, and subsequently I have seen you in many other conferences, how beautifully you have done it using the endo bag and shown the world that there is absolutely no need to worry about fibroids at all. You can tackle it. And when the laparoscope is in your hands, they just obey you.
So, Muralidhar sir, I will tell you 2 words. You are a very big scientific person. And my point is, we are not only talking about operating.
Yes.
We are talking about what is there in the science of fibroid.
Very good.
And
That
what
you
is
have
the sur-
beautifully told us the 4 points.
And we will do it, and we'll see to it that 60% of fibroid surgery is avoided.
Very good, sir. I am really happy that you told the 4 beautiful points. That is the mifepristone, prolactin, and the other points. And I'm sure with that, we can conquer the fibroids without surgeries, 60% of them. And thank you very much for enlightening the whole people here. Thank you very much, sir.
Thank you.
Thank you.
Thank you, sir.
Thank you, Pai sir. Thank you, Trivedi sir, for this wonderful session. And now we move on to our most interesting third session, which is the debate. And this is a very...
There's one quiz question.
Before the debate, yes, thank you, ma'am. Before the debate, we have the surprise quiz question for today. And the winner of the surprise quiz question will get a certificate and a book, which is a practical manual of lap and hysteroscopy gynecology surgery. So we like to always encourage our winners. And now, can I have the surprise quiz question on the screen, please? So the surprise quiz question for today is, which of the following diagnostic procedures is used to diagnose endometriosis? Pelvic laparoscopy, manual pelvic examination, MRI of the abdomen, or an ultrasonography of the pelvis? So I encourage everyone to reply because we have this wonderful book for the winner. And the winner will be announced in the next episode of the webinar. We have about more than 100 participants. I'm sure we'll get about 100 answers today. So thank you everyone who participated. And now for the next most interesting debate session. And for this, I invite my chairpersons for today.
Diksha, sorry to interrupt. Just before we go ahead, I think Dr. Subhash has joined back. So Subhash, if you're there with us, can I request you to kindly say a few words, please?
Yeah.
Yeah. Thank you, Priyankur, very much for this wonderful opportunity. Again, I would like to thank Professor Alka Kriplani, Dr. Achna Baser, and the star of the day, Dr. Pratibha Singh Madam, for this wonderful opportunity. Again, I would like to thank Dr. Sai also. I wish the program best of. I apologize for the delay because I was. Thank you very much. I wish this program the very.
Thank you. Thank you. Thank you, Dr. Subhash.
Thank you so much, Dr. Subhash. It's always nice to have us have you with us in our webinars, especially today when our debate is on laparoscopy for all infertile patients. And we would be very glad if you could be with us and probably share your inputs as well. And now on to our debate session, and I invite my judges for the same. So can I have the CVs for the judges? Our first judge for today is Dr. Gaurav Desai. Dr. Gaurav Desai is Assistant Professor, say, GS Medical College and KEM Hospital. He's a university undergrad and postgraduate teacher, MOGS Managing Council member, Joint Assistant Secretary Journal OBGYN India, and fellow gynec endoscopy and oncology with over 35 peer-reviewed papers. Welcome, Dr. Gaurav.
Thanks, Disha.
Our second judge for today is Dr. Monica Gupta. Monica ma'am is Professor, Safdarjung Hospital, New Delhi. She's a fellow in urogynec and pelvic reconstructive surgery. She has special interest in urogynec and critical care obstetrics. She's secretary of AOGD and NARCHI and is very, very active in all the forums. So welcome, Monica ma'am. Dr. Monica is here.
Thank you.
Yeah,
Thank you, Diksha.
Yeah. Hi, ma'am. So can I invite Gaurav sir to introduce our debaters for today?
Sure. Can I have the CV, please?
Yeah.
Yeah, I'd like to first invite Dr. Aarti Luthra. She is a director and gynec laparoscopic surgeon at Luthra Maternity and Infertility Center, the president of Dehradun OBGYN Society, and joint secretary of UPIG 2021. She's got multiple awards to her name and a very accomplished career. Welcome, madam.
I think we'll start the debate first. Yes, Dr. Aarti. Yeah, you can
Please
start.
unmute yourself, ma'am.
Okay. Good evening, dear friends. First of all, congratulations, Dr. Pratibha, Dr. Priyankur, for this wonderful series. And it's very much different than other webinars. Like you have quiz, you have debates, and you have a very exclusive lecture. So it's our pleasure to be here with you. And I have with me my dear friend, Reema Sarkar. Both of us are from Dehradun and we work in harmony. But we are going to have some fun, Dr. Reema here. And we work in total, coordination otherwise. Let's see today how we create some excitement for everyone. So I'm going to talk on laparoscopy for all infertile women. And I'm going to start sharing my screen. Is it visible?
Yes, yes.
Yes, ma'am.
So the topic is tricky. Laparoscopy for the all word is tricky. Laparoscopy for most of infertile women sounds more interesting. And when we meet an infertile couple in our clinic, it's not the operative part or the most advanced part on which we jump upon to. This is for the audience information that it's always good to follow the ASRM guidelines for fertility evaluation of an infertile couple, and it has to be systematic, it has to be cost effective, keeping all the relevant factors in mind and starting from the least invasive methods. So starting from the fertility history, the gynec history, obstetric history, medical history, proper family history, history about the male partner, and then we have to examine the lady and we have to consider her complaints like complaints of oligomenorrhea, amenorrhea. We have to check for the signs of androgen axis like hirsutism, acne. We have to rule out common endocrine disorders like thyroid and everything. And the ASRM guidelines, they indicate that the tests which should not be routinely ordered, laparoscopy comes first for endoscopic for unexplained infertility. Of course, after doing the basic test, it's very important to find out whether the couple is practicing cohabitation on the ovulation days, whether they are following the ovulation days by LH kit or by following some app if the lady has regular cycles of, or if she has undergone few cycles of follicular monitoring by TVS. And we have to assess her ovarian reserve by doing basic tests like AFC, AMH, and day 2 FSH. And once we examine everything, still she's not getting pregnant, the mind goes on tubes, that whether her tubes are good or not. And the question arises here, should we send her for HSG or sonosalpingography, or do we take her directly for endoscopy? So if the lady has all other normal report, a younger lady, and ultrasound findings are normal, then it's always go for the basic non-invasive test first. And if there are other abnormalities, then we can, like if she has a big ovarian cyst, if she has large submucous myomas, we can tell her to opt for laparoscopy rather than going for HSG. This is a very interesting study in the World Journal of Laparoscopic Surgery, which discusses HSG, laparoscopy, or both in the diagnosis of tubal disease in infertility. And the study concludes that HSG has limited value for accurately identifying tubal patency. And if the HSG reporting is doubtful, it's always good to go for endoscopy to check for very fine signs of diseases which cannot be picked up on ultrasound and HSG. Like you cannot see very fine markers for mild endometriosis like Allen-Masters windows, small endometriotic spots you cannot see. And you cannot confirm the status of beautiful fimbria. You cannot assess the good tubo-ovarian relationship on ultrasound and HSG. You cannot appreciate the ovarian texture, although ultrasound tells us about PCO appearance. But if there is some associated pathology and you happen to see these large, shiny, smooth ovaries, laparoscopy is the gold standard to assess tubal pathology, especially in cases of endometriosis, to check for tuboperitoneal relations, adnexal adhesions, and to find out other intra-abdominal causes of infertility, as shown in this article in Journal of Human Reproduction. Everyone is fond of endoscopic surgery because you cannot refer all your patients for ART, because first you would like to see and treat the problem. And then, of course, nowadays it's laparohysteroscopy. All patients who are offered endoscopy for fertility enhancement, they are combined with hysteroscopy. It can be done if it is not a long procedure as a part of daycare surgery. And in long run, it is cost effective also, because once you correct the disease, the lady has a chance to try for pregnancy every cycle. Few disadvantages with laparoscopy, which Dr. Rima would be highlighting. I think I'll skip that. They need GA, and sometimes, rarely, there can be some complications. So I would like to highlight the benefits of doing laparoscopy in cases of infertility. It's needed in cases of unexplained infertility to assess the tuboperitoneal factors in endometriosis, myomas, especially submucous myomas, if there are multiple adhesions, PCOS associated with other problems, other pelvic pathologies, if there is hydrosalpinx, and LAP before IVF in cases with large hydrosalpinx, and LAP is to be offered after failed IVF also. I'll quickly prove my point for each of these indications. In cases of unexplained infertility with normal HSG, this is a very useful study which says that HSG does not give complete information in cases of unexplained infertility. And patients with unexplained infertility with normal HSG, when they undergo diagnostic laparoscopy, the results of fertility treatment are definitely better. Regarding endometriosis, there is always a dilemma whether you take your patients for IUI or you offer them surgery. It depends upon the grading of endometriosis also. And I would like to mention the beautifully charted Foxy GCPR for treatment of endometriosis. Look at this lady. She has bilateral large endometriomas. Someone offered her HSG, which showed normal tubes, and poor thing, she kept trying. But you look at the distortion of pelvic anatomy, and one can imagine that she has to be rarely lucky to be conceiving easily, until unless we sort it out and we get rid of these large endometriotic cysts, and we correct the tuboperitoneal relationship, and at the same time we release these adhesions which are completely obliterating the pouch, and both the ovaries are stuck to each other. And of course, this patient, once the anatomy is restored, she would have better chances of conceiving either with IUI or with ART, depending upon her age and number of years for which she has been trying. So the GCPR says that medical management in the form of ovulation suppression is ineffective in improving the pregnancy rates in cases of endometriosis, and laparoscopic ablation or excision and adhesiolysis would improve pregnancy rates in stage 1 and 2 endometriosis. And operative laparoscopy should be offered as compared to expectant treatment to increase the pregnancy rates. And excision of endometrioma, that is cystectomy, is the recommended line of treatment. And we must counsel the patient regarding the reduction of ovarian reserve sometimes following surgery. And if it is a repeat surgery, then one has to be very reserved in taking the decision. After endometriosis, PCOD. No one likes to take these PCOD patients for laparoscopy, but if a patient has been trying for induction of ovulation with letrozole or clomiphene and metformin, and she's been following the lifestyle modification, diet changes, induction is not helping, then the second line could either be laparoscopic ovarian drilling if there is other pathology, if the tubes are not good, or we can offer them gonadotrophin stimulation. Still, if we don't get the result, then that lady can opt for ART. Again, hydrosalpinx pretty common amongst infertile women. The ultrasound will show a retort shape like swelling, and the tube may be patent, but one can imagine that this thinned out, distended tube won't be functionally good to perform. And even if this lady has to go for ART, these hydrosalpinges are to be clipped or they are to be removed. This is a lovely study from ASRM journal, which talks about the role of salpingectomy for hydrosalpinx prior to IVF. And the study says that in women with hydrosalpinges, preliminary lap salpingectomy or proximal tubal occlusion would improve the subsequent pregnancy and live birth rate by as high as 50%. Another very common problem, as we know, 30% of women may suffer with fibroids. And as the women are planning pregnancy at an advanced age, the incidence of fibroids is higher amongst these women. Depending upon the location, if these myomas are distorting the cavity, if they are large multiple myomas, or if they are submucous myomas totally compressing the cavity, then we have to get rid of these myomas. Look at this one. This is completely obliterating the cavity and compressing. So if the lady doesn't conceive naturally and she has submucous myomas, like look at this myoma, it is nicely projecting in the cavity, the big myoma, and this is a large fibroid polyp occupying the whole of cavity. So we have to get them out before we offer good chances of pregnancy outcome in all these women. Adhesions, again, cannot be picked up by examination, by ultrasound most of the times. And as this study in JMIG says, that laparoscopy is the gold standard for diagnosis of subtle fimbrial pathology, peritubal and periovarian adhesions. So if the lady is not conceiving, the ultrasound may look normal. The HSG may show slight spill, but these things cannot be picked up. And if we correct these adhesions, lot of times the fertile outcome is much better. Or we can pick up the pathology, like in this patient, you can see that tubes are nodular and they are swollen. And here we see what the surprise is lying for us. There are tubal adhesions and we can see caseous nodule here. And now we know the cause of pathology and we can treat it. And then of course, later on, we can offer her ART. Another common problem which I wanted to bring notice is chronic endometritis, which is not laparoscopy, but endoscopically, whenever we combine lapro and hysteroscopy, chronic endometritis is one cause for repeated implantation failure, recurrent pregnancy loss, and unexplained etiology, and which can only be picked up on endoscopy, where you can see very fine micropolyps on the surface of endometrial cavity. And once you treat it properly with antibiotics, the results are very nice and the pregnancy rate is amazing. Another thing which sometimes can be missed on ultrasound are synechia. Sometimes thin synechia, they may lead to infertility. And once you sort them out, the results are amazing. And everyone knows if we have to diagnose them, it can be picked up on HSG or they can be nicely shown on sonosalpingography. So the reproductive surgery gives very good outcome if done in selected cases, and it is the opportunity to have more than one pregnancy after a single surgical intervention, which makes it the procedure of choice as stated by Victor Gomel, and the lady can try to conceive naturally. So, of course, endoscopy has a significant role in infertility as the cost of IVF is prohibitive for many, and many patients may refuse IVF for religious or ethical reasons. So, I feel that before we take our patients or before we decide to offer ART to our patients, like look at this lady, all the findings were normal, but here you can see small endometriotic spot in UV fold, small bands of adhesions in pouch of Douglas. You know, all these things, they cannot be appreciated and corrected, and we cannot offer ART to all these patients. And to improve IVF outcome also, laparoscopy is important. And of course, finally, you know, we have to work in harmony, and surgery and ART would be complementary. And the selection of treatment should be based on the clinical findings and circumstances of each couple. I thank Dr. Pratibha and everyone for choosing this topic. It was really exciting to be preparing for it.
Thank you.
Thank you,
madam.
ma'am. Yeah. Thank you, ma'am, for your most emphatic yes to laparoscopy in all infertile patients. And now can I invite Dr. Monica to introduce our next debater, Dr. Reema Sirkar, and then we can have 2 minutes for rebuttal to both the debaters. Dr. Monica, please.
Yeah, so after hearing that interesting take of Dr. Aarti, I now invite Dr. Reema Sirkar to speak against the motion. She is a fertility consultant and IVF specialist who's done fellowship in reproductive medicine from London, and she is also an ICOG fellow in gynae endoscopy. She's center head and consultant IVF specialist Indra IVF Dehradun, an ex-associate professor of gynae GMC Faridkot, Punjab. So let's see what she has to offer. Dr. Reema, please.
Thank you so much. So let me start sharing. Can you all see my screen?
Yes, yes.
Yes, ma'am. So, good evening, all. I am Dr. Reema Sirkar. So, all the esteemed seniors, dear judges, Dr. Pratibha, thank you so much for having me here. Dr. Aarti ma'am, and all the fellow colleagues. So Aarti ma'am has very well and emphatically put her point across, and yes, all the points are very well taken. However, ma'am, in the next few minutes, I am going to convince the House why laparoscopy is not for all infertile patients. So laparoscopy, as we all know, it is one of the tools to evaluate female pelvic organs, along with salpingography, TBS, 2D, 3D, hysteroscopy, SIS, and MRI. Let's just go a little back in time in the year 2000, when the ESHRE in its workshop conducted at Capri gave us guidelines, and it said that for evaluation of infertility, at least 3 of the tests are very important, which are semen analysis, mid-luteal progesterone, and assessment of tubal patency. Even by them, diagnostic laparoscopy was recognized, but questioned for its absolute necessity. And it was said that it should be reserved as a further diagnostic procedure only, or if at all, in combination with any other endoscopic surgery. However, this is not 2000, and let's see what has changed in last 20 years in the usage of laparoscopy for diagnostic and therapeutic purposes. Let us also see, can we now, in the present scenario, define to what extent can we perform laparoscopy for fertility investigation and for treatment. For the purpose of ease, I have also divided my presentation into various indications for laparoscopy, and starting with diagnostic one. DHL is one of the commonest surgical procedures performed for fertility enhancement, and almost 40% of patients undergo DHL during fertility workup. It is generally accepted that diagnostic laparoscopy is gold standard in diagnosing tubal pathology or endometriosis, adnexal adhesions, and other intra-abdominal causes of infertility. Advantages, ma'am has already enumerated. We can see and treat combined with hysteroscopy, daycare surgery, something that looks like this. However, if we do look at any pathology using common imaging modalities, let's say ultrasound, 2D ultrasound, this is how I would compare it to be. This is something that the view of a room using an imaging would be. And this is how laparoscopy would show it as. You just go inside the room and look at it directly. Of course, that is advantageous. However, we now come to the disadvantages of diagnostic laparoscopy. Cost effectiveness. Why use such an expensive procedure when you can actually have a fair enough and good look at the pathology, good modalities in a well-trained hand, like 2D ultrasound, even 3D ultrasound is now available, and SIS. So cost effectiveness is really a question. Need for GA. All of us would agree that laparoscopy in the end is an invasive procedure, and need for GA makes it even more, troublesome or questionable. Complications and the possibility of it. And for what? The risk-benefit ratio analysis has to be done, that why should we be taking all the risk of these complications and giving it to our patients? Do we really need them? Adhesion formation, one of the complications. And sometimes all of us would have to agree that doing a laparoscopy does lead to performance of procedures that may in the end be unnecessary. When the patient anyway has to go in for ART, then really why subject the patient to some of these unnecessary procedures? In the end, coming to ASRM, in its November 2021 committee meeting, as ma'am has also said, they have recommended that laparoscopy is not to be considered as a routine evaluation for an infertile woman unless there is a suspected pelvic pathology or another specific condition like severe dysmenorrhea. Second indication that we will talk about is test for tubal patency. Rightly so, as ma'am also pointed out, nice guidelines given by RCOG. They said HSG is to be would be a good enough test for tubal patency in all the patients who do not have any comorbidities, and laparoscopy is only to be reserved for as a tubal patency test when the patients have some comorbidities like a PID or a previous ectopic pregnancy or endometriosis. So even for this indication, laparoscopy is not to be used routinely. In fact, if there's been a normal HSG report within the last 10 months, there is actually very less chance, less than 5%, that there could be a tubal occlusion, and it should rather can be avoided. Moving on to our favorite, endometriosis. So again, going back in time, this was a very old meta-analysis in 1997, I think it was conducted, wherein it combined a lot of studies, and then they demonstrated the advantage of laparoscopic surgery only if it was to be combined with an operative procedure in the same sitting. It was not to be done as just see and come out procedure, but to see and treat kind of procedure. The same was upheld till 2013 when the ESHRE gave its guidelines, and they also said, okay, fine, go ahead and perform laparoscopy to diagnose endometriosis, although they said a histological diagnosis accompanying it would also be necessary. Moving on to ESHRE guidelines, what has happened in this month itself is that on 2nd February 2022, ESHRE has come up with a newer set of guidelines. And here is a 360-degree turn in evidence. What is new in these guidelines is that these are refuting. Earlier, we used to depend upon laparoscopy as the gold standard in endometriosis for diagnosis. Now they say that they are recognizing that laparoscopic surgery, despite its widespread uses, It is expensive, it is invasive, and it is associated with significant morbidity and mortality. So they have also said, although looking at the lesions in a direct and photographic manner is good, however, it is still questionable whether to expose all the women to this expensive and invasive procedure. And they have in fact said that practically a two-step approach that they have now offered is a good, nicely performed transvaginal ultrasound followed by empirical treatment. That is, if a patient is showing some signs and symptoms, they in fact recommend to give them a trial run of progesterones and just to see the result. And laparoscopy should only be reserved to patients in which they have negative imaging results or where empirical treatment was also unsuccessful. So they have also said that now offering laparoscopy routinely to all the patients suspected of endometriosis, they are no longer recommending it. Similarly, for ART in ASRM stage 1 or 2, that is minimal and mild kind of endometriosis, they are again not recommending routinely performing the surgery because the live birth rates are anyway the same. Similarly, if there are endometriomas, on ultrasound, then they have divided the treatment here into two parts. If you are considering leaving patient for natural pregnancy, if you would be allowing an expectant management after endometrioma, then these patients may benefit from taking up the patient for endometrioma removal by laparoscopic surgery. However, if ART is anyway planned for the patient, for example, if there is any other factor which is causing infertility, then they are not recommending to routinely perform surgery, as they say the current evidence shows no benefit and surgery is likely to have a negative impact on the ovarian reserve. That was about endometriosis. Moving on to fibroids. We all know myomectomy is an option for women who wish to preserve their uterus or enhance fertility. Removal of submucosal myomas by a hysteroscopic myomectomy enhance the rates of conception, and yes, agreed, they are to be followed if there are, the surgery has to be followed if there is submucosal myoma. However, benefit of any kind of laparoscopy for treatment of So IM myomas, it is not established, as well as subserosal myomas also. The routinely laparoscopic removal is not being recommended. Here is a study which showed that fibroids, which was only more than 3 centimeters, only they had a deleterious effect on the live birth rates. So that is why the smaller myomas, it is not recommended to remove them. This is another study which showed intramural fibroids prior to IVF. They had 168 women, which showed that only fibroids which were more than 5 centimeters, when the patients were allowed to choose between myomectomy and expectant management, only in this kind of patients where they were large, more than 5 centimeter fibroids, that the clinical pregnancy rate and the delivery rates were significantly better after the surgery. Hence, generally, less than 5 centimeter IM fibroids are not removed, and more than 4 to 5 centimeters IM fibroid only, myomectomy may be advised. Again, it has to be individualized, not a routine kind of recommendation, especially if they have more than some IVF failures or some pregnancy losses and large fibroids, only then it can be considered. Subserosal fibroids, I've already told, they have no impact on ART outcomes, and generally they are left without any surgery. PCOS. So control ovulation induction, we all agree, with or without IUI still remains the first line of management, along with diet, lifestyle modifications. Some of the literature recommends to consider LOD in cases of failed COH with IUI. Even the recent Cochrane review also says that LOD is as effective as gonadotropins in women with clomiphene-resistant PCOS. Also, there are no risks of multiple pregnancy rates as compared to gonadotropins. That is why this option looks attractive. However, again, concerns of long-term effect on the ovarian function are very much real. The ease of having gonadotropins, the effectiveness with the gonadotropins is so much better. Then why subject the women to same kind of results and to an invasive procedure? So again, I would again recommend that the risk-benefit ratio should be carefully analyzed before proceeding with LOD. So where does this bring us? Is laparoscopy really outdated? We all know as gynecologists, it's really not possible to reject laparoscopy altogether as and clearly document it as an outdated procedure. But keeping in view the newer practices, every time you decide to take up a patient for laparoscopy, you should actually question it whether it is really needed, and the answer should come from the scope of evidence-based medicine data. As we all know, the evidence-based medicines comes from individual clinical expertise, but also from best external evidences. And of course, the patient values and expectations are always to be considered. So in my viewpoint, when an apple can be cut with a simple knife, why resort to swords and daggers? Cost, risk, benefit ratio. Please keep it in mind. And hence, to conclude, diagnostic laparoscopy is not an integral part of infertility evaluation, even prior to or after failed IUI, IVF. Benefit of diagnostic therapeutic laparoscopy in endometriosis and PCOS and even in fibroids is not established. Yes, it is still indicated for a few conditions like hydrosalpingosis, where it is clear-cut indicated. For adhesions, again, I would not say the benefit is clearly established. ART and LS, as ma'am also pointed out, are not mutually exclusive, but are coexisting and complementary treatments. Knowledge is a tool, and like all the other tools, its impact is in the hands of the user. Be very wise. Thank you.
Thank you, Dr. Reema.
Dr. Aarti, if you want to revert.
Yeah, Reema, congratulations. Excellent presentation. So, yeah, I loved listening to you. I think diagnostic laparoscopy is an obsolete term now. Like, I have not written this word for ages. It is laparohysteroscopy, and which has to be offered in selected cases in whom the routine tests are not helping the lady to get pregnant, and where we are suspecting that the endometriotic cyst is big, or the myoma is submucous, or the PCOD is not responding at all to our stimulation protocols, very selected patients. And sometimes adhesions, sometimes like we have to pick up the diagnosis of tuberculosis, unexplained infertility, and you go inside, or failed IVF also, I believe. You would be a better person to talk about pre-IVF hysteroscopy, although I favor it because IVF is such an expensive procedure. So better to see and assess everything before offering them ART. But I love the topic. And now let's see what Dr. Gaurav has to offer as his final comment.
Yeah, so thank you, madam. I think both the speakers spoke very well. I love the arguments by Dr. Reema and the whole presentation that both the presenters made. So personally, my view is that we have to try and go to a more cost-effective way of practicing gynecology for infertile patients. Being a developing country, we can always, first and foremost, provide safe and effective care for women, but try and reduce on the cost. Of course, laparoscopy has advanced as far as the safety goes. There are many procedures which are being performed not only in cities like Bombay, where I am, but even in the interiors of India, which are very safe. So that is a good thing. But of course, we can improve on imaging technology. We can improve on 3D ultrasound that will try and detect even more pathologies. and not to forget clinical examination and history, which are also important in infertile patients. That being said, each infertile patient should be treated on a case-to-case basis. But definitely, I think the arguments made by both sides were very apt, and congratulations to both speakers.
Thank you, Dr. Gaurav. Can we have Dr. Monica's viewpoint also? Monica, ma'am?
Yeah, Riksha. Thanks, Dr. Gaurav. I think I echo your thoughts on the presentation, especially. They were wonderfully made. Dr. Aarti, Dr. Reema, I guess they left no stone unturned to prove their point. But personally speaking, yes, I being, part of one of the biggest tertiary government setup, I would also probably, like to say that we really have to look into the cost benefit analysis. And of course, I must congratulate Dr. Pratibha in choosing such a tricky and enigmatic topic, laparoscopy for all infertile patients. Now, this has many things hidden within this topic itself. She cleverly, probably omitted unexplained infertility from there. She cleverly never said that whether it is diagnostic or whether it is therapeutic. And she made both the debaters have the wonderful go at it. So in their viewpoint, I think Dr. Aarti was also right, and Reema beautifully, proved her point. But at the end of the story, I guess, personally speaking, when we come to laparoscopy, even through the points which Dr. Aarti made, even she somewhere kind of proved that laparoscopy would eventually be very, very effective when it comes down to the therapeutic part. So having said that, if we say laparoscopy for all the infertile patients, I think we have to take it with a pinch of salt. And I think I would give that to Reema when she says, do look for the cost benefit analysis. And I congratulate both the speakers for wonderfully presenting their point. And I guess the enigma still remains. And I thank Dr. Pratibha to invite us here.
Was me already.
Thank you to both our debaters who did such a wonderful job and leaving the dilemma still there, whether laparoscopy is needed for all infertile patients. So I think that's a debate well done. And thank you to our respected judges for a most wonderful being there with us and for their most wonderful comments. And because the debate is still on, we had a poll question as well, so that the audience can also participate and give their viewpoint, whether they feel that laparoscopy is really needed for all infertile patients. And everyone can have their say in this debate.
Oh my.
And we still
So
have
I think Reema can have the cake today.
The topic was it was not meant to be for all the patients, but
So I think both the
that's
winners,
that's why I'm
ma'am,
congratulating Dr. Pratibha for choosing a clever topic. She very cleverly chose the topic, and that created the debate. Congratulations once again.
Thank you, everyone. And I now invite Pratibha Singh, ma'am, to formally end the session and to thank all our esteemed faculty, presenters, and the audience for being there with us today.
So it was wonderful, and I'm here to propose vote of thanks. But before I start, I really want to acknowledge love, affection, and encouragement by all our viewers who have joined today. And I'm really overwhelmed by your inspiring remarks and valuable presence. Because success of any conference depends on the presence of delegates. So thank you so much for joining again and again to this knowledge update series. And this time we have more than 100 participants. So thank you, friends. And I promise to bring more such knowledge-packed sessions in future also. And with this, I would like to thank our guest, Dr. Alka Kriplani Madam, Dr. Archana Baser Madam, and Dr. Subhash Malya for their blessings. And thank you so much for sparing your valuable time and making this webinar worthwhile. Then my sincere gratitude to Dr. Prakash Trivedi sir for sharing his knowledge and experience with us. And now my heartfelt thanks to our chairpersons and judges, Dr. Murlidhar V. Bhai sir, Dr. Surjit Kaur Madam, Dr. Gaurav Desai, Dr. Monica Gupta for their valuable inputs. Thank you for joining and giving your valuable time and inputs. And our debaters, they were really excellent. Very tactfully, they have proved their points. So congratulations to both of you, Dr. Aarti, Dr. Reema, for accepting the challenge and making the debate so interesting and fruitful. So thank you so much. And my appreciation to our showstoppers, Dr. Priyankur Roy and Dr. Diksha Goswami for smooth coordination. Thank you so much for being there. And finally, our academic partners who have been supporting us since last more than 1.5 years. So I'm really thankful to Shield Connect for their total commitments towards KU web series constantly. And thank you, Mr. Saurabh, Ms. Chitrikala, and Mr. Steven for their smooth assistance. And now again, we'll be coming up with our next webinar soon. So till then, good night and goodbye. Thank you so much for joining. Thank you so much. Thank you.
Thank you, madam. Thank you, Priyankur.
Thank you.
Thank you.
Thank you.